Thank you, Dr. Kushi. And it gives me a great pleasure to welcome all the faculties and my EC members and the delegates who have joined online to this webinar, which is on sarcoma. And this is the 11th webinar in our series of the academic program this year. All the webinars have been successful so far. This particular episode is being dedicated to Dr. Anita Borges, who is supposed, who is the queen, who was the queen of pathology in India, and we unfortunately lost her last week. And I would request Vinita Pant, who has worked closely with her, to speak about Dr. Anita Borges.
Thank you, Dr. Toprani. I am indeed very grateful and honored that you have asked me to talk. What can one say about Dr. Borges? I mean, I don't think we can, one person or anything we can say. Her professional achievements and skills were unmatched. She was, I pay my respects to her as a doctor whose personal integrity steeped into all her work. She created an environment of honesty. She unwaveringly did right by every patient. She held high standards in the lab, not because she wanted to clear audits or get corporate business, but she knew that would be in the best interest of the patients. She resolutely and successfully stood against commercialization of her practice. She was personally very generous, but she was no nonsense. Uh, as a, I was very privileged to work at her side. For me, reportings used to be a series of why. She would just say why, or she would say just pick up the phone and talk, or she would say how is your report going to help the clinician. Uh, She was my mentor, and amongst the many lessons I learned from her, the most valuable lesson was to chase the diagnosis to its final conclusion and that everything should make sense. Uh, she said it is a privilege that you can understand how tissue looks under the microscope and how it reacts to disease. I say farewell to her with the most respect and gratitude, knowing that her legacy will live on through the numerous very able students she has mentored. She has given pathologists in India, including me, a benchmark to achieve and excel. Thank you.
So, you have very aptly described her qualities. And just to add one more, she was so popular amongst us surgeons, amongst surgical oncologists. And we really liked the no nonsense attitude that she had. And we would get very clear cut diagnosis answers from her, which would really help us in making clinical decisions. Let us, in honor of Dr. Anita Borges, maintain a 1 minute silence. Thank you. Just to add one more thing to Dr. Anita Borges, I forgot to mention that she was one of our past executive committee member of Indian Society of Oncology. And more importantly, she was also one of the recipients of the endowment, the Tata Oration in the past before a couple of years. So she was so well respected in our association. So let us move forward to our academic commitment for this episode, and I would hand over the mic to Dr. Sabita Jivnani to take over.
Thank you, sir, and Dr. Vinita for giving us insights into this great lady's life. I will now request Dr. Vinita to please give us a talk on challenges in the diagnosis of soft tissue tumors. and what the pathologists really struggle, what they deal with, and how they finally try to make all the clinicians happy. Over to you, madam.
Okay, thank you so much. I'll share my PowerPoint. Can you see it?
We
Still,
were seeing it 1 second, just 1 second back, and
still
now
not, ma'am. Still not.
Can you see my PPT?
no, we
Still
can't.
not, ma'am.
Okay. Just a minute. I've pressed share. It's saying uploading. Is that fine?
Wait for a second, ma'am.
Neerav, please check.
Still, it has not come on the screen, ma'am.
Share with anyone with a view link.
No. Just a
Neerav, will it be feasible for you to share it?
yes. Just give me a second, ma'am.
Yeah.
Wait,
Doctor.
I'll just see. Try again. Huh?
Yeah, yeah.
Share the window.
Yeah, share the PPT window.
No.
PPT, where you open the PPT last.
Madam, you're sharing your desktop screen. You minimize the Zoom
It
screen.
says
Minimize
share
the Zoom.
screen.
Yeah, minimize the Zoom screen and then share your screen.
Okay, let me
Open
see.
your PowerPoint.
Share entire screen.
Yes, now minimize the Zoom screen. You have to minimize the Zoom screen before you share it.
Now?
Yes.
Put
And
it full
then,
screen.
Make
yeah.
it full screen.
Okay.
Okay.
Yes, perfect.
Okay. So in soft tissue tumors are rare tumors, and it is and not all of us are working in a DMG kind of a setting. Most of us are deal with these tumors alongside the other cases that we handle. Now, it becomes even more challenging as we enter the era of precision medicine. Earlier, one size fits all concept is no longer applicable, and in every aspect of diagnosis, prognosis, theragnostics, or and documenting recurrence, the diagnosis expected is very specific. Now, I'll take you through the journey of how we've reached this. So, surgical pathology. Now, surgical pathology, the term itself is explains the earliest so-called pathologists were actually surgeons. So this subject started with observations made by surgeons during surgery and followed by observations made during autopsy, and in the earlier 20th early part of the 20th century, this specialty evolved on its own, and that furthered by the development of technology like microscopes, followed by looking at this finding after the gross, then the microscopy, different types of stains were came up, and so you could see the cells in their different you could use differential staining and try to separate out, and earliest classifications began with that. Then in the 90s, I remember when I was an MD student, the new kid on the block was IHC. So everybody was very thrilled because now not only could you see the gross, you could see the microscope, under the microscope, the cells. You could also see the proteins expressed by the cells, and that would help you further try classify tumors and see their behavior, and treatment could be accordingly changed. Now, over the past years, we've entered into the era of precision medicine where we've left the proteins and now we've gone to the genetic level. Now, in 2006, when this TCGA came in, this TCGA was, I think it was one of the most important events of this data being available to everybody for study. And this has evolved in giving us an understanding into cancer basically is a disease of the genes. So it gave us a molecular basis of cancer, subtyping of tumors, and therapeutic targets, and it is still evolving. Uh, for me as a pathologist, once the genome unfolded its secrets, and then various tumors were studied, the genomic patterns of those tumors were studied. You know, IHC was surrogate IHC markers were developed, and it improved the overall precision of our diagnosis. I remember, in fact, when I used to, when we used to see giant cell tumors in 2010, we had very strict instructions, in fact, from Borges ma'am itself, ki you will not sign out any benign giant cell tumor of the bone unless you know the status of the parathyroid. Do you know what is going on in the patient? Today, to some extent, the histone marker, which was discovered because of this study of the genome, the methylation patterns and of these tumors, we can be very specific. We can not only be very specific, we can also work on very little tissue. Sometimes you have, minuscule tissue on which you would not be able to say anything except that, okay, that doesn't look malignant. But today, even with about 10-15 stromal cells, if they mark with the histone marker for GCT, you, in the appropriate clinical context, you can give a diagnosis of giant cell tumor. So the precision in diagnosis is really taken to a different level with these markers. Same for synovial sarcoma. We would go through a panel of markers. We would do CK, EMA, MYC2, BCL2, calpanin, and then, okay, there's no necrosis. A lot of subjectivity was involved. Today, with the rearrangement specific surrogate IHC marker SS18, even a tiny bit of tissue, you can with confidence call it as a synovial sarcoma if it is expressed. Of course, there are caveats everywhere. I mean, these are not markers that are there 100%. They have their own issues with sensitivity and specificity, and that is why hopefully a pathologist will never go out of a job, because ultimately at the end of the day, you may have anything, but it takes somebody to put everything together. Of course, therapy, you would know better than me. Yeah, molecular, once we give a particular diagnosis, then the molecularly targeted therapies make a lot of difference to the prognosis and the overall survival of the patient. As a pathologist, I look on to sarcomas as, based on the molecular and genetic features, as two distinct types. So there are sarcomas which have a very distinct karyotype, and there are sarcomas which have a complex karyotype. Now, the distinct karyotype sarcomas are the ones where some kind of specific targeted treatment can be thought of or can be developed. And for me as a pathologist, a clue to recognizing these is that they are really monotonous. They look very monotonous because there is a distinct genetic event. Whereas the sarcomas that have a complex karyotype, they are very pleomorphic. So you can see the sarcomas that I have, they are like MPNSTs, pleomorphic sarcomas, the osteosarcomas, the high-grade osteosarcomas. So these are sarcomas that have a complex karyotype. There is no specific treatment which can target the genetic event, but there are other treatments that can be that are being worked on for these tumors. Now, that broadly divides sarcomas when I'm faced with a sarcoma. So I want to know, is this a distinct karyotype or is it a complex karyotype? So I'll start with the first case, which is a 38-year-old male where we received, that's the next challenge the pathologist faces, that we get true cut biopsies. You don't get the whole tumor because the techniques have been refined, and thankfully FNAC is on its way out. And so the challenge lies to diagnose the tumor before it is taken out whole. So the This is an extra rectal pelvic tumor, and the PET scan basically showed a weakly metabolic mass in the rectovesical pouch. This is a big mass, 8 into 10 centimeters almost, and we have a young male. So when I look at it under the microscope, it is also weakly metabolic, and that is also reflected in my histology, where it's basically this, you can, at least this is a better part, it's basically a very myxoid tumor. It's a myxoid tumor which has got fine vascularity. It's got pleomorphic cells. I suppose, I think I can demonstrate that at this part also. You can see that pleomorphism means different types of morphology. So you can see that each cell has its own mind. It's got its own appearance. There are round cells, polygonal cells, the nuclei are big, small, and everything. Not only that, they've got this mitosis. They've got bad. This is a tripolar mitosis, which is an atypical mitosis. This is a bad sign. So what we have is a myxoid tumor, which is pleomorphic. It's got mitosis, and it has also got vacuolated cells. If you notice, the cytoplasm of the cells is bubbly. It is vacuolated. So here you can see the cytoplasm indenting the indenting the nuclei. So basically, I'm trying to say that these look like lipoblasts. So here another, these vacuolated cells. But at the same time, it's not that you don't get mucin-filled cells that look like that. So what you have is something which has got features of a myxoid tumor with the pointing towards maybe lipoblasts are there, maybe of a liposarcoma, and but it's very pleomorphic. Now here is where the catch comes in. Now the differential in this case, like I already said, that you're looking at a sarcoma. Or so when we look at tumors, at least in my mind, that has been whatever, it's a broad differential. Is this a carcinoma? Is this a sarcoma? Is this a lymphoma? Is this a melanoma? Is this a germ cell tumor? So that's the basic 5 broad headings under which, the moment I put a slide under the microscope, I first try to classify it. Now, in this particular case, with this morphology, putting everything together, I would basically be thinking of a sarcoma or a mucinous carcinoma. I'm not going into the other differentials. We can take a theory class on that. So basically, we're talking of a pelvic tumor in a 38-year-old male, a big pelvic tumor with this morphology. These are the 2 differentials. That's a sarcoma with a myxoid stroma, or a mucinous carcinoma, which come under the differentials. Now coming to the next stage, the earlier chart I showed you. So we moved the earlier gross finding is not with me, but I have the PET scan instead. So I take that's why when I ask you for the PET scan, when I ask you for the imaging, that is the reason I don't have. So my subject has evolved from gross to microscopy to IHC to now molecular. So I have to make sense of it in the same stages. So I have a good idea of the gross. I know this is a large tumor, which is weakly metabolic in the pelvis between the rectum and the bladder. I know the age, I know what my morphology, I know my differentials. With that, now I choose to see what is the protein expression on this tumor. So I do my markers. CK is for epithelium, SMA desmin myogenic markers, and here comes S100. Now S100 can come positive in neurogenic tumors, or it can come positive in lipomatous tumors. And I'm almost I'm quite sure that I'm dealing with the lipomatous tumor. Now, among lipomatous tumors, you know that there are different types of liposarcomas. You have the importance of, it's not like we are nitpicking or doing it for some academic exercise. The importance of differentiating the different types of liposarcoma lies in the fact that they respond differently to radio and chemotherapy. Most importantly, it is imperative on me to tell you this is a myxoid liposarcoma or not, because myxoid liposarcomas are sensitive to radiotherapy, and that is how uh, that is where there it is important for me whether I stratify the others or not. to make sure that I can tell you whether it's a myxoid liposarcoma or not. Nowadays, the well differentiated and dedifferentiated liposarcomas are also coming up, because I think there are, I'm not very sure, but I think there are some MDM2 inhibitors also in the market. So that therein lies the reason why I have to make an effort ki even if I have come to the diagnosis of a liposarcoma, I have to further stratify it into groups where the treatment is different. Now, obviously, in the face of it, I have myxoid stroma, I have lipoblasts. So why shouldn't I call it myxoid liposarcoma? Now, why should I think of other differentials? So here, the catch is that myxoid liposarcomas are not pleomorphic like this. You do not have these many mitosis and so much pleomorphism. So then I went on to go to a step further and take my protein, and take my IHC workup to trying to, I've come to the conclusion this is a liposarcoma, and I take my IHC workup to see whether what type of liposarcoma it is. There are some surrogate markers that help us, but in this particular case, nothing helped. So MDM2 would point towards a dedifferentiated this would not be a well differentiated liposarcoma. So if it is dedifferentiated, it still retains MDM2. So that would point to that. Now, DDIT3 and SOX11 are surrogate markers for myxoid liposarcoma. This tumor is not expressing those two markers. So now again, where am I? So at that time, that is when you start scratching your, madam used to say, when you are scratching at the end of the bucket. Then you do your readings and you find your WHO manual, and then you come across this lesion, which is a exceptionally rare aggressive adipocytic neoplasm, typically occurring in children and adolescents. Our case is not an adolescent, but he is 38 years old. He's not of the age that you get pleomorphic liposarcomas or dedifferentiated liposarcomas. So with that, putting everything together, whereas there is not one feature which is like, it's not pointing, but when you put everything together, you put a 38-year-old male who's got this kind of a histology, the diagnosis is a myxoid pleomorphic liposarcoma. This is an entity now described in the WHO, and it lacks the gene fusions and amplifications of myxoid liposarcoma, atypical lipomatous tumors, and dedifferentiated liposarcomas. So I'm just trying to explain the thought process behind coming to a particular diagnosis. Now, when I diagnose this case very smugly, we all seek approval, and especially from ma'am. It was it was natural for me to just try to tell her ki, you know, ma'am, see, I diagnosed this. So I went and took that case and I showed it to her and I said, ma'am, see this, and I'm going to present this in. So we have a teaching forum for pathology students, which is every Tuesdays and Thursdays. Madam was very passionate about that. We did not have the energy to attend it. Who wants to finish work and then go at 7:30 and start teaching students? So we would bunk it, except when we were called to present our cases. But madam would very, very resolutely, from 8 to 10 at night, she would sit on Tuesdays and Thursdays and take postgraduate lectures for students from all over the world. This was an online teaching program which covered more than I don't know the exact extent, but definitely it was an international thing. And this started during COVID, because that time we had some time, and she, you know, she wouldn't sit. So she said, okay, we are not seeing. Our lab, by the way, never stopped during COVID, but but the caseload was low, so so she started, not we, she started the online classes, and these online classes used to go up to the attendance of about 1,000, 1,200 at a time. And subsequently, of course, now once COVID has stopped and the attendance is not thousands, but she still carries on with the classes with a very, very good attendance. So this, she told me ki, now, so what is so you are just going to show I like that case, I diagnosed that case? No, there has to be a message. So this is a case which she personally, she chased things to the end. She gave this case personally to me and said, you will put this slide as a comparison with your case to show the difference between myxoid liposarcoma and a pleomorphic myxoid liposarcoma. Also, the clinical picture. This is, myxoid liposarcomas are extremity tumors which occur in the extremities. In the retroperitoneum, you do not get myxoid liposarcoma. So that was the take-home message. This is her case, which she personally emailed to me, and I'm very grateful to her for these small lessons that take us a long way. And the ultimate message she wanted to give was that in the abdominal cavity, commonest lipomatous tumors are well differentiated and dedifferentiated liposarcomas. Myxoid liposarcomas and myxofibrosarcomas are tumors involving the extremities. But areas resembling these tumors can be seen in dedifferentiated liposarcomas. Do not make this diagnosis in the abdomen. She would chew us up if we would make a diagnosis of myxoid liposarcoma in the abdomen. And rarely, very rarely, in the younger age group, there are outliers. You think of a diagnosis of a myxoid pleomorphic liposarcoma if everything else is excluded. So that brings me to the other point in pathology. So are we doing tests only to diagnose something, or sometimes we have to look at it the other way. We not only use markers to diagnose something, but we use markers to exclude something. Like in this case, we excluded the other diagnosis. This is not a carcinoma. This is not a neurogenic tumor. This is not a CK-EMA also excludes out chordomas and all. So the second case I'd just like to show you, just to highlight how the other point that she was very particular about, that is history. She's pick up the phone and call. So this is a male who has multiple liver lesions, and you look at it under microscope, and for those of you who are conversant with the pathology terminology of epithelioid appearing tumor, this is an epithelioid appearing tumor. It's got abundant cytoplasm, it's round to oval nuclei, it's against a loose myxoid background. And when you look at this, then the differential as a pathologist, you have a 38-year-old, I think, 47-year-old male who's got multiple lesions in the liver. You're looking at, is this a neuron? And this is, by the way, a tumor which is not very pleomorphic. It's got a relatively monomorphic tumor. So the first thing that comes to your mind is a neuroendocrine tumor. Then you think of other things like METs or melanoma or sarcoma, or maybe a primary tumor from the liver itself. So I did my panel, so went on to do the IHC, and I found that nothing, no epithelial markers to say CK-EMA is negative. The synaptochroma rules out the neuroendocrine, and the HSA arginase excludes the hepatocellular origin of this tumor. Now what? So normally this would be the stage that we are stuck at. So at that time, I called up the clinician and I asked him, can you send me, what is the thing? Can you send me the imaging findings? So at that time, I was told that this is a liver SOL, and there are multiple SOLs, and there is some irregular thickening in the distal jejunum. That is when the penny dropped. Now we know that one of the commoner tumors in the jejunum and is GIST. So that's when I put the markers CKIT and DOG1, and this tumor was brilliantly positive. So this is a GIST. Now GIST usually comes up as a spindle cell tumors, but these tumors don't follow any rules. So there are times when it can come and mimic an epithelial tumor. So in this particular case, it had an epithelioid morphology, and the clue lay in the history. I knew there's something in the jejunum, so I thought of putting those markers to confirm my diagnosis. Of course, now with the thing, any epithelioid, just you have to rule out an SDH deficiency. This did not have the loss of SDH. So basically, so this is an epithelioid GIST, gastrointestinal stroma tumor. You would know better than me how much the treatment is affected by the different differentials, and once I say it's a GIST, how the treatment would entirely change. So basically what I want to say is that the clinical presentation and morphology form bedrock. You cannot do without it. You use IHC either to confirm your diagnosis, or you have to have a diagnosis in mind when you put your immunos. Like in CKIT and DOG1, I confirm my diagnosis with the IHC, or you exclude the differentials with IHC. Like in pleomorphic myxoid liposarcoma, I excluded the other diagnosis. Then, of course, there are tumors, a small amount, where you will not be able to sort it out. And now, with the emerging technologies, FISH, PCR, and NGS, they help to make those diagnoses, like in undifferentiated round cell sarcomas. And now, even in spindle cell sarcomas, those are coming up. And that is an evolving field. And I think next year, the WHO 6th edition is going to come up and open another panorama, another lot of tumors, where we will be hopefully be able to be more precise and give you a more specific diagnosis. I end with this. This is when you give a heterogeneous, when you give me a true cut biopsy, this is what me and my pathologist colleagues actually face. And I would like to say that the person who taught me to look at the whole elephant is now no more. But I think and I have to thank her for the guidance that she has given me, and through all her students, her legacy lives on. I thank you for your time.
Thank you so much, madam, for that really, really interesting talk and making it so useful. I mean, I'm sure all the clinicians in the audience were enthralled by our talk, and I, for one, could not miss even one slide. So thank you so much for making this so interesting.
Thank you.
We now move on to our panel discussion on challenges in the management of recurrent sarcomas, a subject that demands both experience as well as fresh thinking. Moderating this session is the Chief of Orthopedic Oncology and Head of Department of Surgery, Dr. Ajay Puri, known for his intelligence and sharp wit, and he'll be steering the conversation with our panelists with insight and clarity. Over to you, sir.
Thanks, Anita. Hi, good evening, everyone. I'll just begin sharing my slides, and while that's happening, somebody needs to stop their screen sharing. So,
Yes, sir. They've stopped the screen sharing.
you can see my slides?
No, sir.
All right. I seem to be facing the same issue that
Yes, sir. We can see your slides. You'll need to go to
yeah, full screen mode, but all right.
all right, sir.
Perfect. So I have a very eminent panel with me. I mean, starting with Anita herself, who's going to be the pathologist involved in this. For radiology, I have Dr. Amit Janu. Medical oncology is Dr. Samir Rastogi. And for radiation oncology, we have Dr. Minal, and the surgeons are Mandeep Shah and Anand Raja. So welcome all of you. Thank you very much for joining in. I hope that you are not polite, you disagree with each other so that we can have an animated discussion. I'll begin with this case. It's a 33-year-old who had an unplanned excision and presented to us immediately after the initial surgery. The pathology was an undifferentiated pleomorphic sarcoma. Imaging showed residual disease locally in the thigh, and it was non-metastatic on imaging. So that is the background. I'll start off with Vinita. Vinita, this diagnosis of undifferentiated pleomorphic sarcoma, you sort of just a few minutes ago told us how we chase it to its ultimate and try and find out. How often would you give this diagnosis still, or would you be able to narrow it down to a particular pathology?
Undifferentiated pleomorphic sarcoma, there is a whole there's a whole lot of IHCs. So you put the now pleomorphic sarcomas can be different types. Now, whether it's a spindle, epithelioid, so the IHC panel would vary depending on the morphology, but it does require a very exhaustive IHC panel. You have to, this would fit into my earlier first case that I presented. You have to exclude out everything else before you come to a diagnosis of undifferentiated, meaning you exclude out adipocytic, smooth muscles, rhabdomyoblastic, neurogenic. So you rule out those, you use markers to exclude those differentiations on a by IHC, which is on a protein level, and then come to this diagnosis. And apparently, and obviously, this is an undifferentiated pleomorphic sarcoma, so it will be by definition pleomorphic. It would be like I said in the first slide, it would come under the complex karyotype type of a tumor, I would maybe throw in a P53 or a MIB or something to give you some idea about it. But it requires a huge IHC panel before you can say undifferentiated pleomorphic sarcoma.
So now my question is to the surgeons and the med-oncs initially. Does it make a difference to you? I mean, if she calls it undifferentiated pleomorphic sarcoma, you just go ahead, or would you really force her to give you a specific diagnosis? Maybe we can start with Anand and Mandeep, and then we can have Samir chip in.
As far as Dr. Mandeep, do you want to go first?
No, you start. No problem.
So, if I am contemplating resection as the first modality of therapy, I would kind of want to know whether the UPS diagnosis that is given is a diagnosis of exclusion, that you've ruled out everything and you've landed there, or are there possibilities to give a little more diagnosis? I would not be bothered too much about trying to pin it down to a particular subtype if I am going to do upfront surgery first, because that way we know that sarcomas are very heterogeneous. So the specimen is out and you can do all your studies there. All that I'm interested in knowing whether it's a sarcoma or not, low grade, high grade, that would suffice if I'm doing upfront surgery first. But if I'm contemplating neoadjuvant therapy, then I'd like to know what it is, because I'd like to give or not give neoadjuvant therapy based on the specific diagnosis that I have.
So let's take this case. No, before Mandeep comes in, Anand, let's take this case. I gave you the background. This is residual tumor now. What would be your plan for this?
Yeah, so I am assuming here that I can see that there's a scar, going around all the way from the subcutaneous to around the vessel. There would probably have been a lot of disease there. A large chunk of tissue has probably been removed from the from the excision site there. So I'm assuming that a lot of tissue is available for pathology, and that UPS here is like the final diagnosis that you can give me after analysis of all the slides. So my treatment here would be default for majority of the cases. For sarcomas, we give neoadjuvant radiation and then take up for surgery. So I'd be happy with a diagnosis of UPS here and then plan for surgery.
And so you would be giving this pre-op RT?
Yes.
Okay. Mandeep?
I would differ a bit. I would probably do an upfront surgery, resect the vessels out, put in a new,
No, you jumped to the second question. The first question was, are you willing to accept UPS or would you chase the
So I agree with Anand in the first question. If I'm contemplating upfront surgery, I'm happy with this broad diagnosis of UPS. If I'm contemplating neoadjuvant radiation, then also I'm okay with this broad diagnosis. But if I'm contemplating a neoadjuvant chemotherapy, yes, I would want a specific diagnosis.
So in this case, you said that you are contemplating upfront surgery, unlike Anand, who says pre-op RT.
Yeah, because
Can I come in here once?
Yeah,
As
sure.
I understand it, when you are saying UPS and I would want a specific diagnosis, UPS is a specific diagnosis.
Correct.
Yeah, but
so it is not an NOS that we cannot specify it. A pathologist will give a diagnosis of UPS only after they have excluded everything and said, okay, now it cannot be things. So UPS is a definite WHO entity.
So it's not a diagnosis of exclusion is what you're saying?
Yes, it is a diagnosis of exclusion for me. But when I write out UPS, for you, it's a definite diagnosis, which means that this is a sarcoma which has got no specific differentiation at the protein level, at the IHC level. Now, what molecular throws up, we'll have to see.
So now that Anand and Mandeep disagreed, I'm going to bring in Amit Janu. Amit, unfortunately, I've kept only one image, but this was the most representative image. Do you think the vessels, what is the amount of sort of encasement of the vessels? Because Mandeep, if you're saying upfront resection, I presume you're going to contemplate a vascular resection, or you feel
yes, sir. If I was the primary surgeon and I was doing the primary surgery.
No, you are not. You're seeing this
so
now.
In that case, I would probably have separated out the vessels. But here, with the contamination of that kind, I would certainly want to resect the vessels out, irrespective of whatever is the encasement level.
Amit, you want to comment something on the
Yes, sir.
vascular
If you see
encasement?
that, then definitely the vessels are actually compromised, and if you see it is at least partial encasement, and if there is a chance that there is a partial encasement, there is a probability that it might be adherent. The tumor might be adherent, even though it is a residual disease, but it might be adherent.
Okay, so fair enough. So basically, we are not proponents of pre-op RT, but in this case, we decided to sort of give pre-op RT to try and avoid major vascular resection because we thought that otherwise we'd have to sacrifice the vessels. And that's exactly what Mandeep said. Considering he's trained by us, it's good to know that he's stuck to the same principles. After pre-op RT, this was the imaging. Amit, you have any further comment
So
as to
yeah,
whether it's made a difference or no? I can go back and forth.
definitely. So artery looks
So this is the
relatively better.
pre-RT, and this is the post-RT.
So if you see the dark void that is there, then it is mostly the femoral artery, and that looks to be relatively, it is abutted, but I don't see any areas of infiltration. But yes, the vein, I don't know whether it is looks compromised still.
Perfect. That's why we love Amit. So this is what happened. When we went down for the resection, we had to resect only the vein. The artery could be separated out. And then comes the question now, as a surgeon, I'll go back to Anand and then Mandeep both. If you have to resect the vein, or even say the artery and the vein, would you reconstruct both, or would you reconstruct only the artery?
So we published a paper on this. So what we've argued in our paper is that there's no choice. The arterial reconstruction is a no-brainer. We'd always reconstruct. Whether we use biological or prosthetic graft is a different issue altogether. But insofar as reconstruction of the vein is concerned, to a very large extent, it depends upon whether the vein is abutted or whether it is infiltrated, and what is the flow going through the vein, and what are the collaterals that are going to form around the vein, and the volume of tumor that you are resecting. If the vein is completely occluded and you have sufficient collaterals, then reconstructing the vein would not make that big of a difference, because the collaterals would already have formed, and whether you reconstruct or not would not make a major difference. But sometimes we end up resecting veins because they're completely encased, so on and so forth, when there is still sufficient venous outflow going through the veins. In these cases, we reconstruct the veins. We know that they'll eventually thrombose, but we believe that the venous collaterals that have formed just because there's flow through the veins is insufficient, and over a period of time when the vein thromboses, there will be more time for the collaterals to form, so the eventual limb edema will probably be a little bit lesser if you reconstruct compared to if you don't reconstruct. That's the best answer I can give you, sir.
Okay. Mandeep, you want to improve on that answer?
No, I think we really don't reconstruct veins, because eventually, as Anand pointed out, they all thrombose. And as far as we have the profunda and everything intact, even the great saphenous system is intact in this particular case. I don't think there is any point in.
So in this particular case, you would not have reconstructed the vein.
We usually don't reconstruct veins, sir.
Okay. So good to know that Anand remembers his paper. This is what Anand exactly mentioned, that they do not reconstruct the veins if they are completely obstructed, whereas if they are non-occlusive veins, then they would reconstruct knowing that they thrombosed. His graph shows that the vein actually thromboses pretty early, but his point about it giving some time for collateral circulation to develop is valid. But we again do not reconstruct the vein. We have found that its thromboses quite quickly. So here, only because the vein was sacrificed, there was no reconstruction and we had clear margins. Now I'm going to bring in Minal. Minal, in this case, we had clear margins. But once we have given pre-op RT, suppose we had got positive margins, would you give an RT boost or you would say it makes no difference? Hi, do we have Minal on?
Hi, sir. So I'm saying that, good evening, sir, that if it's a margin is positive, then we should give a radiation boost to the lesion, which should be around 60 to 66 gray to the dose, to the margin
No,
positive.
so the patient would have already received about 55 gray, considering
Yes,
you're doing pre-op RT, and then you would give a boost?
Yes,
Because
sir.
I'm just telling you, our radiation oncologists believe that a boost actually doesn't really add too much of increment. So I just wanted to hear your thoughts on this, the pros and cons of giving a boost versus not giving a boost in case after pre-op RT we have positive margins.
So on positive margin only it has benefit. Otherwise, it doesn't have. For R0 section, there is no benefit at all. But for R1 and R2, we have definite benefit in it.
Okay. So Anand
Dr.
and Mandeep.
Minal, Dr. Minal, I'd be very interested to know, because this is a focal margin positive that comes up. How do you identify where is the focal margin positive and where is it that you want to give the boost? It'd be very difficult to identify that. So you'd probably end up having to give to the entire scar or to a large portion of the scar.
Yes, so mostly it
So
is like that. But if the surgeon puts a clips, na, and he can provide us the answer to it, like whether it's a deep margin, whether it's a lateral, which lateral margin it is, that can be given by the histopathologist. That can be easily done, like we do in the sir head and neck cases also. The same cases can be done in this case also.
So
yeah,
I'm
but
going to bring, so Anand, I'm going to interrupt you because you can take this up further with Meenal and Mandeep too. So we know that, as surgeons, when we want to save critical structures, especially if you've given pre-op RT, sometimes we take planned positive margins. Say rather than sacrifice the sciatic nerve, we would take a planned positive margin knowing that evidence has shown us that it's not that the evidence of local recurrence is much more. In these cases, we at TMH actually don't add a radiation boost, knowing that it's a planned positive margin as against, say, contaminated margin. Mandeep, your thoughts on it, and then we'll go to
Yes,
Anand and back to you.
we follow the same methodology. We follow same protocols. We don't really add additional radiation to the already pre-op RT patient.
And Anand, what about you?
I completely agree with what Dr. Ajay Puri and Dr. Mandeep have said. We don't add radiation. Just one more point. Even in the plant positive margins, we know that the plant positive margins after radiation are not the same as the plant positive margins. Even when you do upfront surgery, they are a little more innocuous. I don't have too much data to back me up, but we know that after neoadjuvant radiation, if it's a plant positive margin, they don't behave very badly.
Fair
Focal
enough.
margin
So
positive.
mostly those papers are for low grade, I think so, sarcoma, not for the high grade ones.
No, Meenal, for low grade, we wouldn't even actually think of RT.
Think of RT. Yeah, that's right.
So anyway, so that's the point. Now we come to Samir. He was waiting for so long. Samir, any role for adjuvant chemo in this?
Thank you, sir. Sir, am I audible?
Yes,
Yes.
yes.
Sir, so first of all, this is UPS. Would you consider adding chemotherapy with radiotherapy in neoadjuvant setting or immunotherapy? Because now we have stand up to see SUC 32 trial in which phase 3 trial in which neoadjuvant pembrolizumab was given concurrent with radiotherapy, and the DFS 2-year DFS increased by 15%. So would anyone like to consider adding pembrolizumab for in neoadjuvant setting for UPS when randomized phase 3 data is there?
It's still very small data, Samir. I don't think so.
Yeah.
In this case, we didn't. So I'm asking you now for adjuvant chemo in this.
Yeah.
Would
So
you give?
adjuvant, sir, I will need exact size of the tumor, because the first surgery, if it was like 6 or 7 centimeter, and then now again it is 2 centimeter. So I will use circulator as a marker of recurrence, that if I'll take age, it will be grade. Grade is mostly UPS 3, and then size of the tumor, and then histology, of course, UPS. So if the chance of recurrence is more than 50%, then
I thought circulator talks about OS, not recurrence.
sir, it talks about 5-year distant metastasis also. It talks about probability of 10-year OS also.
All
If
right.
probability of 10-year OS is less than 60%, then the benefit of chemotherapy in absolute term is almost 10 to 15%. So, but even if it is 8% or this percent, so I'll still consider this is a young guy, and tumor seems to be, what is the original size, sir, which was the surgery was done?
Okay, 7 centimeters.
So I think that it will classify as high risk tumor, and I will, in this young chap, I'll go for chemotherapy.
No, so that's what I'm saying. Will you use circulator, or you will decide that it was more than 5 centimeters deep, young fellow, I will anyway give chemo
No, I'll
irrespective of
use circulator, but in this case, if it is UPS grade 3 circulator, 40 years, it will be, the OS will be around 60%. So I'll, of course,
OS is
60%.
AOS is 80%.
Okay.
33-year-old, 7 centimeters, FNLCC grade 3, UPS 3.
Sir,
I mean UPS.
okay.
5-year OS 86, 10-year OS 80.
Okay, sir. Sir, what is the, I mean, they get 5-year chances of distant mets also. If it is somewhere 30%, I might consider, but then this is a good risk, but still, I'll still discuss with him. I mean, in this, evidence is not there. In less than 60% OS, evidence is definitely there.
So, Samir, that's what I'm saying. Evidence is not there, but we'll still give chemo, means we'll give chemo to everybody. So,
Sir,
as per circulator, okay, let's go. As per circulator, this patient is not a candidate for chemo. If we are
yes,
following
as per
circulator.
circulator, it's not a candidate of chemotherapy.
Okay.
The benefit would not be to the tune of 15% absolute, but we cannot rule out 5% or 10%. So that's what.
So here, largely, we use any excuse not to give chemotherapy. So we didn't give chemotherapy. Still non-metastatic, so it was metastatic. Now, 4 months later, patient presented with local recurrence bordering the RT field. On the left side is the site where it was initially the surgery was done. And then now you have a local recurrence occurring on the border of the RT field. So now I'll come back to Vinita. Vinita, when we have, you spoke about FNAC being outdated and now no longer done, we don't do it. But if it's a recurrent tumor, we want to document recurrence, would an FNAC be adequate for you?
If it is yes, in a setting of recurrence, if it's a well done FNAC, I think compatible with a known case, yes. In that setting, FNAC would be fine.
Could you also
I don't
tell
like
us-
it in a primary diagnosis, especially when you have something like an undifferentiated pleomorphic sarcoma. But in a setting of recurrence, an FNAC is okay.
Are
When I
there
have,
any? So in
when
recurrence,
I will
is there
take
any
your
time
PET
where you
scan
would
report.
insist on more
Sorry, I will take
samples?
your. I'm sorry. I'll take your radiology report, and I'll talk to Dr. Janu, and then I will report it out. But I'm
Okay.
okay with it.
So now we'll again come back for comments to the surgeons, to
Sir,
the
my
medoncs
question-
and the radoncs.
Sir,
One
my
by one.
question, I have one question.
Yeah.
Sir, in this particular patient, it has come up just in 4 months. It has all the radiological features of this being a recurrence. Would you still do an FNA?
So it's in the local area. I don't think it's really mandatory, but we follow a policy because we talked about FNA. We actually just do put in a needle and just get a diagnosis. Maybe it's being medico-legally very safe, but I take your point that when it's come up within 4 months in the bed of surgery, field of surgery, is it mandatory to document local recurrence? Practically, no. Medico-legally, I think that an FNA is, very minimally invasive. We would still do it.
Correct.
So now let's start with the surgeons. Mandeep and Anand.
So what I think would probably have happened here is that the original surgery that was done, he would have, whoever has operated, we could see there was disease probably around the vessels to begin with, because there's a linear scar in the skin and in the subcutaneous space. There was disease around the vessel, and to remove this tumor, I think a lot of contamination would have happened within the operative field, so to speak, where the disease was there. And then we are left with whatever little disease was there, and then we gave radiation, and then the tumor shrank. But because of the contamination is what we've had this, because of the intra contamination is what I believe that we would have had this. So my surgical plan is that now I have to go and excise the entire surgical, the original surgical, or margin to begin with. I'd not even see the vessels, put a big incision, if I have to remove it, I'd not see the vessels, cut the above vessels above, below, and kind of remove everything and reconstruct it. That would
So
be.
you would now do an arterial resection as well.
Yes. I'd
Okay.
probably go very far, and I'd not even see the graft or anything. I mean, all that would be part of the specimen, which I'd see later on. I think that would be the best chance for this patient to
Okay.
avoid a recurrence later
Mandeep?
date. It will be.
Sir, I'll first take an opinion from my radiation oncologist whether he is comfortable giving him radiation, whether before surgery or after surgery. Again, because it is overlapping fields.
Okay.
Now, see, if he is comfortable giving RT, this is the case. This is the place where I would probably send him for a pre-op RT, because this is where the
Pre-op RT
I
again.
would want to save the vessels here now.
Okay.
Previously, probably in the first place, I would not have saved the vessels. I would have what Anand
Okay.
describes now. I would have done that in the first go.
Minal?
No.
Mandeep wants you to asking you whether we should give pre-op RT or not.
Yes, so we can give a pre-op party to this case.
Hmm.
And we have to check about the cumulative doses, and but I don't think so that we can give another boost if there is a margin positive disease or something. Otherwise, we can go for a pre-operative disease, 40 gray, 45 gray. We can go up to that.
Okay. So Anand and Mandeep, none of you are asking Samir to give chemo again, or now give adjuvant chemo.
No,
Or
it's
new
still a
adjuvant
localized
chemo.
disease, sir. I mean, it's still a localized disease.
Okay.
The treatment
Amit,
protocol would
any
remain same.
comments on whether the vessel seems encased or we'll be able to save the vessel?
Sir, vessels look okay in this, at least. In this.
Okay.
Yeah.
All right. So we re-excised, we got clear margins. We re-excised without pre-op RT, Mandeep.
Yeah.
So now would you still ask for RT again?
Yeah, I mean, the margins at the best would be close around the vessels.
Yeah, but clear. Vinita has reported clear margins.
Right, but still, of course, this
Okay.
is our radiation.
So, Anand,
I would have done a different surgery, what I said, and then I would have given RT to that. This I'm not so very sure. I would
Okay.
have done a little more major surgery and then given RT. This I'm not very sure.
So, Minal, what about you? Now that the surgeon has said clear margins, will you talk the surgeon against giving radiation again, or would you say go ahead and give radiation?
Yes, sir. Previously, the patient doesn't receive the full dose of radiation, as well as it's a local recurrence also. So
No,
we
patient
can.
received full dose.
No, that time, last time, it was only pre-op party, no, sir.
So
We
pre-op
didn't.
party is also full dose, no? If clear margins is full dose.
No, sir.
Whatever. I mean, okay.
Yeah, sir. So I'll go for an RT again
Okay.
with this case.
So actually, that's what is just published about a week ago. This talked about 5-year local controls, and this came from Jay Wonder's group that said even when radiation has been given, the re-radiation and surgery group local control was 83% versus 68% in the surgery only group. So there is definitely a role. It's not every patient, but you have to be selective about it. There is a role for giving re-radiation also. It doesn't mean if the patient has had radiation once, cannot get radiation again. Now re-radiation given, and you all said, Mandeep and Anand both said that no chemo. What about Samir?
Sir, I mean, he's recurring again and again. Now,
But this is local failure. No
yeah,
meds, na?
yeah, I got your point. But circulator can only be applied for upfront. So even in
Correct.
first, so I mean, evidence that I mean, there is no evidence as such.
So what? You're saying chemo again?
Yeah, I
Or
might
chemo?
consider giving after discussion with him that see the chance of distant mets again in first case if it was OS was 80%, the chances with metastasis would have been 30%. Maybe now they are more.
Okay. And
So
your
I
chemo
might,
would be?
sir, I first doxo.
Okay. So anyway, as you said, we didn't give chemo again. And 2 months later, now he's come with 2 nodules in the chest. First, Amit, this is meds or this is something else or what?
So this is classical meds. It's
Correct. This was a simple one for you. Now those small nodules which occur, especially in a country like India, how would you differentiate, say, between the TSCTs, what do you call those small, on thin slice CT, you see those multiple chota nodules, and whether it's actually met or no? How could you swear and say one is the other or not?
Sir, we will look at what is their distribution, whether it is in the lower lobes, they are randomly distributed, and whether the morphology is actually triangular or polygonal, then it is more likely to be fibrotic changes, but they don't occur in the lower lobes. And if there is entire lung is clean, and especially these are maybe around 30, 40 or 50 years of age group, and otherwise the lung is clean, and whatever we
Yeah,
will
he
see.
was 35, 33-year-old, sir.
So if there is no other lung conditions which actually look like tuberculosis, then these are going to be metastasis in those settings.
Okay. Anand and Mandeep, would you biopsy these before deciding they are mets, or would radiology be enough for you?
Radiology is enough for diagnosing these as metastasis. These are very classical metastatic nodules, classically occurring in sarcoma patients.
Agree.
Small, rounded, peripheral, dull, not in continuation with any
Okay.
vascular
So
markings.
locally, he's clear now.
Yeah.
Short DFI, repeated recurrences. Now even we will give chemo, much as we were not giving. But my question is, considering these are 2 resectable mets, would you give surgical excision for this, an adjuvant chemo? Or would you give neoadjuvant chemo to gauge the biology of the disease, the fact that this is repeatedly recurring with short DFIs?
Yeah.
What would your call be?
Yeah, because it's a short DFS, I would probably err on giving him chemotherapy first, just to see how the disease is behaving.
And then seeing how it progresses.
Yeah, correct.
Okay.
Despite giving
What about
chemotherapy,
you,
if the disease increases or progresses, then it is there is no point in doing metastasis.
Anand?
I mean, I completely agree. It's systemic disease now, so systemic control first before local control. Local control as in lung control. So it's a systemic disease, systemic therapy first.
So,
but sir, I would want to do a PET first, just to rule out any extra pulmonary disease.
Where do you expect extra pulmonary disease besides the local area?
Well, because it's relapsing so fast and multiple recurrences are there, it's very unlikely that it is anywhere else, but it's as a protocol.
Yeah, so Mandeep, to put it into perspective, it was improperly done index surgery.
Right.
The local recurrence occurred in that field, whereas Anand clearly mentioned that, contamination was possible. Right. So I don't think we would do a PET for all these cases. Your point is taken. People are moving towards whole body MRI and PET. And maybe now that you have raised the question, we can get Amit to talk a little bit about, Amit, when you're looking as part of staging, the role of whole body MRI and PET and how justified it is? I mean, yes, we can all do it, but is it required?
Sir, whole body MRI, I will see in that, especially in soft tissue sarcoma, it is doing well. And the only challenge was earlier that in the lungs, now we have the zero echo time sequences in which we will pick up these metastases and we will have the similar characterization almost as compared to the lung. So definitely, as compared to the PET CT and this thing, maybe the only issue that might be remaining is the maybe the metabolic uptake that people used to see it, but that can be actually done with the diffusion weighted MR. So yes, now whole body is coming in a big way, definitely, especially in the pediatric age group.
So Anand, Mandeep, and Samir, collectively, how much of neoadjuvant chemo would you give before deciding that yes, biologically we can either go ahead with surgery or it's progressing? I know, see, even after one cycle, if it progresses, end of story. But how long would you wait before surgically intervening if it was non-progressive?
Sir, 2 to 3
So
cycles of IFOS doxo are usually good enough.
Mm-hmm.
Sir, I have also a point to make, sir. Sir, this is undifferentiated pleomorphic sarcoma.
Yep.
We should also go ahead with PDL1 testing, because if chemotherapy doesn't work, they are very immune sensitive. In fact, the response rate of immunotherapy is 23%. So, I mean, we will just test it for the later time. Suppose if it progresses on chemotherapy after 2 cycles, we might consider giving immunotherapy also if PDL1 is high.
So you are talking 1 minute. So let's now, this is the point I had not included, but if you are saying that, so let me say it progressive after 2 cycles of chemotherapy.
Yes, sir.
Anand and Mandeep, would you talk about giving immunotherapy and then considering surgery, or you would say immunotherapy is sort of, if
Yeah,
Samir wants to give, let
immunotherapy,
him go
and
ahead. We have put our hands up.
I believe so, because if the patient has progressed on chemotherapy, I would probably rule out any surgical intervention in future and probably counsel the patient that this is going to be palliative.
Anand?
yeah, I kind of agree that surgical intervention right now may not be there, but like rightly pointed out, the response rates to UPS for immunotherapy is to the tune of about 25%. So that could be tried here. And then sometimes works wonders. So we could take a call based on response to maybe after 5 or 6 cycles of immunotherapy, 5 or
All
6
right.
months of immunotherapy.
Brilliant. So, Sabita, we've run out of time actually. And we'll then stick to just one case because it's taken up.
So you can continue for 15 minutes more if you want to, and you can quickly wrap up the case. But if the analyst and you want to wind up, that's also fine, sir.
So what happened to that case? Let
So
us
we can ask because 15 minutes now with
No, there
with
is,
the way we
I
are
think
discussing, it won't
you
wind up
can
in
go
15
on for
minutes.
some time, sir. You can go on for the next case.
All
In
right.
15 minutes, till 8:45 it is there, so you can go for the next case.
Perfect. So the second case which I kept.
Sir, just a second. What did you do for that case?
This is just now. We are actually giving neoadjuvant chemotherapy. We have
Okay.
started the patient on, just started on chemotherapy, and we're going to gauge the biology. Exactly.
And what is your protocol at TMH right now?
IFOS Adria is what they give.
And after 3 cycles, you reevaluate?
Yes.
Okay.
And we will evaluate again with local imaging and a CT scan to see if progress anywhere. We have not really considered about immuno yet. We can take that call if the situation progresses. But generally, considering if it progresses, 2 will become 4 and 6, we really would not be very enthusiastic. And by we, I mean Sabita would not be very enthusiastic about going in and removing those.
Just a short question from my side,
Yeah.
if the tumor is responding at the end of 3 cycles of chemotherapy, would you operate at the end of 3 cycles, or would you give the 6 cycles and then operate at the end of
We would operate at the end of 3 cycles because I think that's the best chance. I mean, I think we are of the opinion that when it is a sarcoma, surgery works best. This was just to gauge biology. If at 3 it's not progress, we would resect. And yes, we would back it up with continuous adjuvant therapy as well, chemo. It's not that we would stop the chemo. We would give the adjuvant chemo.
And sir, if the DFS in this case was 2 years, for example, you would have done an upfront metastasis.
Yes, upfront, but then we would have again considered chemo as adjuvant chemo.
Okay.
All right? Okay. So the next one is a bony case. Now, this is a 13-year-old with non-metastatic osteosarcoma of the femur. I'm going to go through the index. So received neoadjuvant chemotherapy. We did a surgical excision, a reimplantation of sterilized tumor bone, which we do, and it completed adjuvant chemotherapy. 9 months after completion of adjuvant therapy on follow-up, we get this in the chest. What now? Anand?
Locally clear, no, sir?
Huh?
Locally clear.
Locally clear, obviously the answer would have been get a CT chest. So I'll show you the picture. Again, this is a solitary lesion in the chest. I didn't think we would go to the second case, so I'd asked Amit that question earlier. But this question which we face, not in this particular case, but we see many upfront small lesions and we are always struggling to find out whether they are benign or malignant. And so there is a very nice article that talks about in the British Journal of Radiology, it's about 4 years old, and how do you differentiate pulmonary metastasis from benign lesions, especially in the lung. So if it's malignant, I mean, what favors malignancy is multiple nodules, especially if it's more than 7. A nodule size more than 5 millimeters would be tending towards malignancy. Nodule calcification tends towards malignancy, whereas a single nodule less than 5 millimeters in a subpleural location would generally indicate benign. Amit, you want to add anything to this?
Yes, sir. Actually, we are having the same thing, especially the subpleural locations within 1 centimeter of the pleura and the fissures, they are going to be benign. Especially if they are polygonal, triangular in the apices, they are going to be benign. And definitely, if they are in the lower lobes, multiple randomly distributed, they are going to be malignant. And the size doesn't vary, especially in the osteosarcomas, because of the ossification. Even they are 2-3 millimeter. Actually, we are able to pick them up.
Okay. So that was sort of put for us. When we came back, we had a single Met. And now the question comes to Samir, and then I'll go back to the surgeons. I'm sorry, Minal, because this is an osteosarcoma. We will try and include you in this, but realistically, in osteo and radiation oncology doesn't have too much of a role. Samir, tell me now.
Sir, the recurrence is within 9 months.
9 months.
Sir, so
9
this
months
is
completion of therapy.
completion of therapy. So, sir, this is not a this is within 2 years. This is early recurrence. I think surgery stands the best chance. I will not give chemotherapy probably.
Okay. So when would you have talked about chemotherapy? If it's not 9 months, when will you talk of chemotherapy?
Sir, if it is like delayed recurrence, maybe 2 years. Or
so
maybe
you are using 24 months as your cutoff, right?
Yes, sir. But we are flexible. I mean, sometimes 20 to 24 months.
Okay.
I mean, yeah.
Anand and Mandeep?
Kind of agree with that, sir.
Sir, I mean, I would probably, I mean, if these are resectable metastasis, we would certainly resect. If it is not resectable, if they're multiple and all, then we'll.
So no, this is a single man. This one is resectable.
Yeah, no. Answering your first question, when will you advocate chemotherapy second? And if this is not resectable, we would certainly send for chemotherapy. Otherwise, we'll resect.
Okay, so after resection, he said, and Anand also said that if it's less than 24 months, they will not give second line chemo. What is your call?
I think I would probably think other way around. I mean, if it is an early relapse, I would probably want to give chemotherapy if he has not received the 3 molecules. I mean, if he has received just sometimes, even today, sometimes patients receive only 2 drugs.
No, so this is, let's presume that this is non-methotrexate based. 3 drugs have been given.
I think I would observe. If I've achieved an R0 in the lung, I would observe this patient.
So you would also less than 24 months not give second line chemo.
We usually don't give second line chemo.
Okay. So perfect.
Unless for palliation, I mean.
Correct. So just to put it into perspective, our decision making for second line chemo is based on the DFI and extent of disease relapse. I mean, if it's a solitary Met like this, then most of us less than 24 months, we wouldn't give chemo. Beyond that, we would. And if we were to talk about giving second line chemo, let us say, as Samir said, it's after 24 months. Then yes, we would give second line chemo, but would you give again a neoadjuvant setting, or would you upfront, if it's resectable, resect it and then send for chemo? Samir, what would you suggest? Then we'll go to the surgeons.
So neoadjuvant setting, it will tell us the biology of the disease.
But biology, we know, it is occurred at 30 months.
Sir, in case we operate, then we will not know how long to give. In case we give high dose MTX and it is responding well, which it does usually in late relapsers, then at least we will be continuing with that adjuvant therapy also. So the long protocol, the high dose MTX and ifosfetoboside alternate protocol.
So you are saying that, say, if the DFI was 30 months, you would still give neoadjuvant in a solitary resectable lung met and then ask the surgeons to do surgery?
Yes, sir.
Anand, Mandeep?
No, we would do, we would certainly operate first.
Anand?
If it's operable, we'd operate first and then give chemotherapy subsequent to that.
I think, Samir, that would be what most of us will do, because with due respect, I mean, surgical cure is still the benchmark. So if it's resectable, yes, I think most of us would operate and then send to you for adjuvant chemo. Not resectable upfront, then we would give neoadjuvant chemo and see that it changes.
Okay,
But,
sir.
okay,
So,
so this is,
one question, sir.
yeah.
If the DFS is 30 months, supposedly, and we are resecting the only nodule, I mean, what is the point of giving second-line chemotherapy? We don't know what's going to work or not.
So
Because
correct. So
we
let's
give him optimum chemotherapy
no.
upfront.
So let's read the slide which I put.
Okay.
Okay. No, exactly your point, but I put this slide for a particular reason, because all of us sort of agreed, including Samir, that if it was a short DFI, we wouldn't give chemo. Long DFI, we may or may not give, open to debate. So this is a sort of, review article that talks of a lot of this thing, comes from a reputed institute that says that patients with unilateral lung or solitary lung mets and DFI greater than 24 months, better prognosis could be managed with surgical resection and close observation. Complete surgical resection is essential for survival. I mean, that all of us accept that, especially in osteo, there is no role for really, if you are not going to do surgical resection, then at best you're adding a few months, you're not really curing. But the interesting point is that they talk about chemotherapy when DFI is less than 24 months. And there are two schools of thought, even if you look at internationally. We believe that a short DFI, no role for second line chemo. Maybe if beyond 24 months, then as Samir said, we have a discussion and we may give chemo. Whereas there is a school of thought that says that if it's less than 24 months, that is when you give chemo. Beyond 24 months, it doesn't make sense. Anand, Mandeep and Samir again.
I mean, I'm of the second school of thought.
Yeah,
If
I
it is
think
an early relapse, meaning by doing a surgical intervention, early relapse, I would be inclined to give second-line chemotherapy. Late relapse, I wouldn't.
Anand?
no, I think if it's within 24 months, we generally operate. If it's operable, wait under observation. Beyond 24 months, we do surgery with chemotherapy if possible.
Okay. Samir, you want to add something before?
Sir, I think same, because this is pretty intensive protocol, 3-drug protocol.
Okay.
And if a person hasn't responded to it and recurs after 9 months, there is very little point in subjecting to again intensive protocol like high dose MTX and other ifosfetoboside.
Okay. Meenal, I'm going to ask you a question because, osteosarcoma, sometimes there is a debate. And we will include chondrosarcoma in this as well because there are a lot of residents listening. Suppose a surgeon has got positive margins in osteo or chondro. Would you recommend giving radiation to that? Do you think that helps local control in an osteo or chondro?
Yes, sir. In positive margin, it always helps.
Even in
you
osteo and chondro?
Yes, sir. Otherwise, you don't have any role in
Anand,
osteosarcoma.
Mandeep?
So we've had this paper from the Rizzoli group, which said that in patients who have had a positive resection in osteosarcoma, they should be immediately recommended an amputation.
No, fair enough. Amputation, so nobody's arguing. If we can improve surgical margins, we will improve surgical margins.
So I
But
don't
let's
know
be
whether
real.
with the advent of proton,
Let's be realistic that once I do a limb salvage,
patient
if I get positive margin, it is very, very difficult to convince that patient to undergo an amputation.
Agreed, sir.
I mean, 9 out of 10 patients will say, no, we'll take the chance. My point is, will you recommend radiation in this or no?
Not, sir. Not the conventional radiation, but I do not know about the proton. I mean, if the proton can be of some help in these kind of situations, because we know traditionally osteo and chondros are radio-resistant tumors.
Anand?
Radiation only if wide surgical margin cannot be achieved in a margin positive case. We've done a hemipelvectomy and you get a margin positive, is probably when I'd recommend radiation. But with extremity, I'd probably offer a margin negative resection, which would be an amputation.
But if patient refuses an amputation?
Then I'll tell him that I'd still offer, radiation. I would not offer radiation. That would be suboptimal in this scenario. I would not offer.
I agree with you. That's what most of us, I mean, yes, an amputation, most of us offer, but practically no patient wants a fairly successful limb salvage, say with a focal positive comes. Very rarely will a patient accept an amputation. Unless I'm just saying, for example, God forbid you get a marrow positive and then you put in a prosthesis really disseminated, then even we are more aggressive. But generally, we would not recommend radiation in osteo or chondro, and that's what the boom also suggested about chondro. But just for the sake of completion, these slides, is there a role for chemotherapy after local recurrence? This is an interesting paper from Stefano Ferrari's group that spoke about 62 patients who had only local recurrence. The 5-year post-local recurrence survival was 53% without chemo, 58% with chemo. Doesn't make any difference. When you had distal metastasis, the without chemo had better survival. But I think that's basically a selection bias that you just gave patients larger disease, chemotherapy. So essentially, second line chemotherapy in osteosarcoma is not very, very hopeful. And it doesn't make too much of a difference. So that is why there is always still a debate, as was seen even in our panelists, whether we would give at the end of second line or no. And then Samir, last question to you. When do you decide enough is enough?
Sir, in osteosarcoma, so nowadays there are too many therapies, cabozantinib, regorafenib.
But do they work? There are many therapies for everything. My question is, do they work?
Sir, cabozantinib has 12% RECIST response rate and 4 months of PFS. In fact, current COG trial has started that in maintenance setting. So in a fraction of them, it works.
But then we subject all of them for this small fraction.
Yes, sir. So far, there is no biomarker, unfortunately.
Anand, Mandip?
For most patients, progression on second line chemotherapy, we'll call it a day. For most patients.
Mandip?
Sir, we counsel them that the treatment, any treatment further other than further now is going to be palliative. Then it is, I leave it to them whether they want to continue or they want to call it off.
So
having said that, I'll take one. If I'll probably agree with Samir in one way. So progression on second line chemo can be multiple types of progression. There is this 4 metastasis that have become 400 metastasis. So those patients, whether you give cabozantinib or regorafenib, they are not going to respond. But those 3 mets that have become 5 mets or 6 mets, small volume progression, in my opinion, probably they would be the ones that would respond to other targeted therapies. So maybe those patients can go on. That would be my view. I may be right or wrong. I don't know.
So I think that is work in progress. But if you look at the systematic review or the meta-analysis that are done, especially relapse conventional chemotherapy, EFS was uniformly poor for these patients. And we agree that there is, a paucity of really things that we can do. And the same is with immunotherapy. You take this phase 2 trial of pembrolizumab, and that showed that it really didn't make a difference. This was a basket of all cases, but the selective osteosarcomas, really not too much of disease. Also with the immunosarc trial that showed selective response in some cases, but in the 17 osteosarcoma patients that were there, the median PFS was 3.5 months. Toxicity profile was also high. So really keeping the cost considerations in mind and the lack of response, as of now, I would still say work in progress for immunotherapy and not much real role. But anyway, thank you very much to all my panelists. It was quite a lively discussion. Thank you so much to the ISO for giving us the opportunity to do this. So, Sabita, back to you.
Thank you, sir. Wonderful panel. I'll hand over to Arvind to give the vote of thanks.
Yeah, thank you, Sabita. And thank you, Dr. Puri. I think a very elegantly moderated panel. I'm hearing you after a very, very long time. So I think it was wonderful to hear you, and you brought about the best in our multidisciplinary panel. I would also like to thank our panelists, Mandeep, Anand, Meenal, Samir, Amit, and Vinita ma'am for their insights. I think I'm sure the over 200 participants that were there online would have immensely benefited from this. I would also like to thank Dr. Vanita for that very elegant case presentation and her fond memories of working alongside Dr. Borges. Of course, this ISO webinar, we specifically had wanted to keep it as a small tribute from our side to honor the remarkable contributions and enduring legacy of Madam Borges. Uh, we also have during the course of the end of this month, that is on October 31st, November 1st and 2nd, we have our upcoming biennial conference, the ISO ISMPO 2025. I'm sure all of you all are getting the emailers. If you have not registered, please do visit our website, register. It is going to be a galaxy of both national and international faculty. Please do block your dates and attend the conference. I'd also like to thank formally our program directors, Sabita, Samir, and Sumant, for all their efforts during this the organization of these webinar, and this is the 11th in our series. Of course, we will break for the next physical event, and I'm sure that we will have one more virtual webinar, the 12th webinar, sometime during the end of November, and we will come back to you for the dates. Once again, I'd like to thank everybody. Thank you, bye-bye, and good night.
Thank
Bye-bye.
you.
Good night, everybody.
Bye-bye.
Thank
Good
you.
night.
Thank you.
Bye.
Thanks
Bye.
to
Thanks,
everyone.
Mandeep, Anand, Vinita,
Thank you,
Meenal,
sir.
Amit.
Pleasure.
Thank
Amit.
you. Good night.
Always
Good
pleasure.
night.
Thank you so
Bye.
much, everyone.
Thank
Good
you.
night all. Thank you.
Thank you, sir.